This is Care of the Child with Special Needs Part 2. You're going to see around Valley Children's lots of different therapists. We have pet therapy that comes, different animals every day. There's a music therapist that comes on certain days, as well as the occupational, physical, speech therapy, play therapy that are there all the time. So this child's getting horse therapy. It's amazing, some kids just really respond to either music or pets, something when they really haven't been responding to anything else. So let's talk about educational resources for children with special needs. Well, it is required, it is mandated that children with special needs get educational services up to the age of 21. This started back with the first law in 1975. That law was amended in 86 to add interventions for birth through age 2 and preschool for age 3 to 5. The laws that we're under now is IDEA, Individuals with Disabilities Education Act, that was established in 2004, and it says that everyone is entitled to a free and appropriate education from ages 3 to 21. There are other services for that under 3, but the school system, the local school, has to provide a free and appropriate education to children with special needs from age 3 to 21. This is hotly debated in court of what is appropriate. If a child can't hold a pencil, then occupational therapy to help them hold a pencil is educationally necessary. Where other people would say, no, that's not, there's no learning there. That is not part of the school's curriculum. So occupational therapy is pretty clear cut, but there are other things that are even more controversial of what is appropriate and what is not. So we also need to have a transition plan. So the school is providing services through age 21 for those severely delayed kids. If they're able to graduate and move on at 18, then they do. But by age 14, there's supposed to be a transition plan established of what will they do after high school. By age 17, we're supposed to have looked into finances for them. Remember, up to 26, kids get to stay on their parents' insurance now, so they have medical coverage till then, but what's going to happen after that? Is their care going to be financed? At 18, if they're competent, then they become an adult and are the person who's legally responsible for themselves. If they're not able to take on that role, then again, legally it needs to be documented, and the person who is responsible for them needs to be identified in the court, so it's not a question. It's known and it's documented. And at 18, we also want to look into, are they going to be eligible for SSI or SSI work incentive? So if they're college bound, if they're capable of doing college work, we need to make sure the college campus they're going to is able to accommodate whatever their disability is, whether that's, mobility, and don't put them in a dorm that's not wheelchair accessible, or special testing because of anxiety, things like that. Make sure that the college knows and is prepared. And then by age 21, it's recommended that they register with the Division of Developmental Disabilities for adult services. When we're dealing with losing a child, and we're talking about end-of-life care, realize we want to honor the parents as well as the child or the patient's wishes. And that should be documented and shared among all the healthcare providers of what is wanted. And even when a child's under 18, their wishes should be taken into account. So you may be used to DNRs, do not resuscitate. That means don't do CPR if the child's heart stops. But oftentimes we do things that are a little less than CPR. So that really should be spelled out clearly. So can we give oxygen and comfort, but not do compressions. I'm often now seeing DNR, DNI, so do not resuscitate, do not intubate. Some facilities are using A&D, which is allow natural death. So know what your facility means by the different letters, acronym that they're using. If we have a child who is not going to survive, we always ask about organ donation. Don't tell a parent your child's dying and can we harvest their organs in the same setting. Kind of bad form also makes it look a little suspicious. Are we letting your child die in order to get the organs? And that is never the case, but we want to make sure it doesn't feel like that to the parents. So organ donation in general, less children organs are available. Parents who are losing a child, that is so traumatic, they rarely can say, yes, go ahead and take the organs. Most of the time, if we're taking organs, that means they're healthy organs. So this is usually a child who's been in a terrible accident. They were healthy, and now they're brain dead. And just on a side note there, in California, brain dead is dead, and the family has no more say. We will turn everything off. They are dead. That is not true in every state. Some states, the family still can choose to keep them on life support. So anyway, so tell the family what's going on, and then in a separate discussion, ask them about organ donation. There needs to be a written consent. It will not cost them anything. The recipient pays, or the recipient's insurance, so it does not cost to donate. Parents are, they're worried. I'm gonna bury my child. Will they look okay? They do. They take out the organs that are useful. The child still will look normal if they're going to do a funeral and have an open casket. Consider the family's cultural and spiritual beliefs. They may have strong religious feelings against doing anything to the body after death. So don't try and talk parents into something that is very disagreeable to them. And just realize in general, they're going through trauma. It is the rare family who's able to see the good that can come out of organ donation when they're in the middle of their own trauma of losing their child. Which brings us to palliative care. We do, as we said before, we want to respect the child's goals and preferences and choices. Palliative care, comprehensive caring. Everybody needs to be on the same page. We want to use the family strengths and the strengths of the interdisciplinary resources. So this is not just the nurse at the bedside. The nurse should be and can be calling all the different resources, the different providers, as well as organizations that can help or be involved. Make sure you're acknowledging and addressing the caregiver's concerns. Don't just focus on the child and forget the parents and the other family members. And then build systems and mechanisms where support is always going to be there. So when we give palliative care, we really are focusing on pain and discomfort. We're also going to provide nutrition. This doesn't mean we do nothing. It just means we're no longer seeking cure, but we are seeking comfort, and if we can prolong the life, we will. Provide emotional support to the family and to the child, and assist the family through the grief process. And how long does grief last for a parent? A really long time. Many will tell you they never get over the loss of their child. They develop a life where that's just sort of part of it, that the acute pain goes away, but they're never fully over it. And odd things can sometimes bring that grief right back up. And, again, it doesn't mean we do nothing, but it does mean we're focused on pain, minimizing pain, and keeping them comfortable. So how do you assist a family through grief? Well, grief begins at the time of diagnosis, and that can be grief of not having the perfect baby you'd been envisioning, and now you have a child instead who's going to have all sorts of medical needs, or it can be the terminal diagnosis. It's common to go through those stages of grief, the denial, anger, depression, and again, if the family is acting this way towards you, you don't have to let people yell at you, but be understanding of what they're going through. Give them a place they can go by themselves and, go through that, get social services involved. At the time of death, people often have physical symptoms. They'll say they feel short of breath, they feel like it's not real, they can't sleep. They may ask why. Why couldn't you save them? At Children's, I know we can say we gave them amazing care. We really cared. We did everything we could, but we couldn't save them. And you may not have a why better than we did everything possible. Family sometimes will get hostile or agitated. Again, try and be understanding, but you don't have to let them take it out against you. And grief does last a long time, and every family is different. And what is comforting to one family may not be to another, so be careful of what you say. Listen to what they're saying and what they're finding comfort in before you say things that may not comfort them. And then grief counseling. And one of the great things with hospice is they'll keep doing counseling with the family for up to 2 years.